Good evening, everyone. Thank you for joining us tonight. It's my pleasure to introduce the Interim Dean of NYU School of Global Public Health, Dr. Melody Goodman.
Good evening. Let's try that again. Good evening.
Good evening.
Thank you. I'm a professor. I need call and response. I'm Melody Goodman. I'm Interim Dean of the NYU School of Global Public Health, and I have the distinct honor of welcoming you to this year's William C. Stubing Memorial Lecture. We're fortunate once again to host this event in partnership with the Greenwall Foundation and our Center for Bioethics at the School of Global Public Health. Before we begin, I want to thank our partners at Greenwall and the GPH team who made tonight's event possible: Dr. Matthew Liao, Amber, Kendra, Chris, Andrew, and Bruce. We would not be here in this beautiful space if it was not for all of you, so I appreciate all that went into putting us here tonight. It is so wonderful to see a room full of students, faculty, and members of the NYU community and the bioethics community, as well as so many people joining us virtually. I want to give a special thanks to tonight's speaker, Beth Macy, and moderator, Perri Peltz. I know that we are all excited for their conversation, so at this time I would like to introduce Michelle Groman, President and CEO of the Greenwall Foundation. Michelle has a wide-ranging expertise in translating bioethics scholarship into real-world applications that affect everyday lives and draw on the experiences to help people realize the Foundation's vision of making bioethics integral to the decisions in healthcare, policy, and research. Michelle, thank you for your partnership in this event, and I'm delighted to welcome you to the stage.
Thank you, and good evening, everyone. I'm not a professor, so I don't need the call and response near but welcome to those of you in the room and those of you joining us by webcast to this year's William C. Stubing Memorial Lecture, Ethics in America's Epidemic, Navigating Solutions and Hope in the Opioid Crisis. I am thrilled to be here in New York City to have this conversation with all of you tonight. I also want to extend my thanks to the NYU School of Global Public Health and Center for Bioethics for partnering with us for this event. At the Greenwall Foundation, we seek to make bioethics integral to decisions in healthcare, policy, and research. How we treat those with opioid use disorder, shape policy solutions to the crisis, and study what works and what does not are all areas rife with ethics dilemmas. I look forward to exploring these complex ethics questions more with all of you this evening. Tonight's topic is one that has touched the lives of so many of us, in this room and across the country. The opioid crisis has and will continue to shape lives, threaten lives, and take lives. How we got here is not one story, but many, and where we are going is yet unwritten. I am so proud to bring you a conversation this evening that engages two experts on these chapters of the American experience and the ethics questions at the heart of them. I could not introduce tonight's lecture, though, without first saying a few words about Bill Stubing, the lecture's namesake, who served as president of the Greenwall Foundation from 1990 to 2011 and passed away in 2015. Under his leadership, the foundation developed its focus on bioethics and became the field's primary private funder. He particularly understood that bioethics needed a pipeline of talent, and he oversaw the creation of the Greenwall Faculty Scholars Program, which remains our flagship investment. Bill was an ordained Lutheran minister and educator who first served as a headmaster of a parochial school and later turned his professional career toward medicine, ethics, and the arts. He relished radical ideas, regularly took risks, and as a funder sought out controversial, important work from which others shied away. The Greenwall Foundation's hope for this lecture that bears Bill's name is to model vigorous and civil discourse on bioethics issues that demand public attention. That's exactly what we're set to do this evening. Bill's impact on this foundation and the world more broadly is profound. I'm glad that we're joined today by his friends and family, including his husband and life partner, Ron Thomas. And I'm glad that we can continue to honor Bill's legacy so fittingly through this lecture series. Now, a few quick housekeeping items before we get started. We will have about 20 minutes for questions from the audience at the close of our moderated conversation, and we will get to as many as we can. If you are in the room, we have cards to write your questions on, available on your seats. You can pass them forward to me or hand them to one of our staff members. Could staff who will be collecting cards give a quick wave? They're around. Thank you. If you are watching online, feel free to submit questions using the Zoom Q&A feature. The webcast video is closed captioned, and we will be recording today's discussion and sharing it following the event. We'll send a link to all of you who registered. I'm now pleased to introduce today's moderator, Perri Peltz. She's a journalist and a public health advocate, and also an Emmy Award-winning filmmaker known for the documentary, Warning, This Drug May Kill You, exploring the devastating effects of opioid addiction and its relationship to Big Pharma. I'll welcome Beth and Perri to the stage, and Perri, I turn it all over to you.
Hi, everyone. Good evening. It is so nice to see so many people, and we are so excited to be here. Michelle, thank you so much. And thank you to the wonderful Greenwall Foundation for not only having us here tonight, but for all the great work that you do. It's a privilege to be here. It's a privilege for me to be here because I am an enormous fan of yours, Beth Macy.
Thank you, Dr. Peltz.
Doctor, no one ever calls me that. I'm so excited. Took long enough to get it. I might as well, right?
Exactly.
But truly, when I was asked if I would moderate this conversation and it was an opportunity to speak with you, Beth, I was so thrilled because I am such a fan of your amazing work. So let me get started by an introduction, because you deserve an introduction if we're going to have this conversation. Beth is a Virginia-based journalist who's known for writing about outsiders and underdogs. Raised in a small Ohio town, she is an award-winning author of 3 New York Times bestsellers that explore rural communities overlooked by corporate greed and political neglect. Her first book, Factory Man, won a J. Anthony Lucas Prize for its examination of globalization's effects. And then, of course, Dopesick, which was shortlisted for the Carnegie Mellon and a winner of the LA Times Book Prize. And it was hailed by the New York Times as a, quote, masterwork of narrative nonfiction. How about that? And then, of course, adapted into a Peabody and Emmy-winning Hulu series, where Beth served as an executive producer and co-writer. Beth's 2022 book, Raising Lazarus, Hope, Justice, and the Future of America's Overdose Crisis, follows Dopesick. Most of us were just hanging out at home, doing a lot of whatever during the pandemic. I can see you weren't. Offering on-the-ground solutions to the drug epidemic. And then in that you were also a 2010 Nieman Fellow at Harvard, as well as a Guggenheim Fellow. You've written for the New York Times, the Wall Street Journal, the Atlantic, and the Washington Post. She has a new book coming out, which we'll talk about a little bit later, called Paper Girl. Beth, welcome.
Thank you.
So happy to be able to have this opportunity to speak with you.
I'm so grateful that you all asked me to, and I finally got to meet Perri, who is being modest. She had a huge role in Dopesick as well with the initial idea. Yeah.
But thank you. What does my mother say? Oh, just say thank you. Right. We'll talk about Dopesick in a little bit, because from where I sit, looking at how does journalism intersect with public health, Dopesick was such an extraordinary way to see the way that reporting can really change so much of the way that we look at an epidemic. So we're going to get to that in a little bit. But I want to start, Beth, because as somebody who has been a journalist more or less for all of my professional life, I have jumped around from topic to topic to topic. You have stayed focused on this sector of the world and the opioid epidemic. How did you wind up reporting on this topic?
Yeah. So it was actually an assignment to begin with. It was 2012, if y'all can think back all the way to 2012. We didn't really know we were in an opioid crisis then. If we were paying attention, we might have remembered that there had been a lot of crime around OxyContin shortly after its introduction in 1996. But it was a long time before we put together the fact that those folks started on OxyContin when it got hard to get, eventually went to heroin, and then later fentanyl. And I was a newspaper reporter in Roanoke, Virginia, at the Roanoke Times at the time. And I wrote a lot about outsiders and underdogs and needy communities, but I was assigned instead to write about this wealthy suburb. And if you've seen the cover of Dopesick with the sort of McMansions in the suburb, that's actually, it was called Hidden Valley. And I did this 3-part series for the newspaper, which at that point actually did 3-part series, doesn't really anymore, following the journeys of these two families. One, the young man had overdosed and died, and the other, the young man, was about to go to prison for 5 years, federal prison, for having sold his former private school classmate the heroin that resulted in his overdose death. And the judge let him do drug court, and I mean, he's out of prison now, and he came to the premiere of the Dopesick Hulu show that we had in Roanoke, and he said, "Dude, I taught you the word Dopesick." And I was like, "Dude, correct, you did." Because I remember we'd drive around and he would tell me, like, here's where I first did drugs, here's where I stole from to get money for drugs. And he said, it wasn't about, like, getting high. Well, at the beginning it was, but then once you're hooked, he said, it was like you would do anything not to have that excruciating feeling of being in withdrawal. And he said, if you weren't gonna see your dope man until Thursday and it was Monday, you would save a little bit of it so you could hold out until you saw him again, because the worst thing in the world was to be dopesick. And I didn't know that word at the time. And so we did this 3-part series, and readers kind of spit out their coffee. Like, what? Wealthy white kids are doing heroin? We had no idea. And in fact, a lot of people had no idea. I had just finished my first book, Factory Man, which was about the aftermath of globalization. And it takes place in these same communities that Purdue targeted later with the pill mills, et cetera, which we still know have the highest overdose death rates, some of them. And I was beginning to hear about, like, that it was just getting worse. And so I said to my, no offense, New Yorkers, I said to my New York-based agent and my New York-based editor, I said, this heroin thing is getting out of hand. I told them about the series I just done. I said, what about that for my next book? And they both went, heroin? We think you're just late getting it in Roanoke, as if it were a trend. Right? Like, you're just not cool enough. What year was this, Beth? This was 2013 at this point. So if you remember, we didn't know that our life expectancy was going down for the first time in history until Deaton and Case economists tell us that our life expectancy is going down, and it's largely due to opioid overdose deaths, also alcohol-related deaths, and suicides. And that was a big, like, holy crap. And then the book Dreamland came out the next year. And so after I wrote my other second book, I came back with more data. And of course, I went back to Spencer that said, dude, I taught you Dopesick. And I just basically started to piece together a story that I thought the average reader could learn about how this epidemic shape-shifted. So it starts out in these rural areas with OxyContin, then it goes to heroin, then to fentanyl, and I tell it through, like, basically this heroin highway, which is Interstate 81 that cuts through every state has a heroin highway, alas. But then I figured out, how to show the epidemic morphing, as it were.
And we talked earlier, the epidemic continues to morph. I came into the story at about 2015. And at that point, my boss at the time at HBO handed me a little clipping about kids dropping dead. It was a little tiny clipping. She's like, why are kids dropping dead? And I'm like, I don't know. And that's how I became involved and was blown away, because at that time, there was such an important story that it was being overprescribed. Mm-hmm. And then young people were getting addicted. And then, of course, to your point about being dope sick, they would shift over to heroin because someone inevitably would say, well, here's how you make that pain go away. Mm-hmm. So it's interesting how you can enter this story at all of these different points. Beth, let's spin back a little bit. Let's just talk about where we are in that story right now. According to the CDC, the U.S. had close to 100,000 overdose deaths this past year. Shockingly, that's a 14% downturn from the year before. So that's good news, if you think about it, that there's a little bit of a downtick. But bad news that we're still at those kind of really high numbers. Where would you place the epidemic right now?
Yeah, I would say it's still festering and growing. A lot of experts that work in harm reduction and really do on-the-ground work, like Dr. Lupi Roy, we know that there is underreporting of overdoses. And just to give you a sense, because we've got roughly north of 2 million people with opioid use disorder. So still losing about, according to the official count, 100,000 people a year, give or take. When Dopesick, the book, came out in 2018, I would say, I always open my talks, and I should have said this first thing, like, I'm sorry for your loss. I know there are people in this room who have lost people. And when you think about the enormity of, it's not just the people we lost, it's their friends and their relatives, and a lot of them are carrying around a lot of guilt around what they did or didn't do. So a third of American families had experienced strife because of the opioid crisis in 2018. Now that number is 2/3. So more people have felt this than haven't, and yet we still have 2 million addicted Americans. And the number that gets me is we have a treatment gap of 87%. That means that in the last year, only 13% of folks of that 2 million have been able to access evidence-based care. So, I mean, if we got a 13% at NYU, that's an F. That's not good. And as I say, a lot of people, why is the numbers going down? I mean, I think a lot of it is due to we've made Narcan more widely available. I'll talk a lot about harm reduction tonight. We have made fentanyl test strips more available. We still have a lot of work to go, though, in terms of something else I'll talk about, which is medication-assisted treatment.
Which we're going to talk about right now. How's
Okay,
that?
great.
So medication-assisted treatment, I think most people know it's using the tools that we have, the medications that we have to treat people with opioid use disorders. Beth, your point about accessing those drugs and the tremendous gap that exists is really extraordinary. Public health students note the word is stigma. We're going to get there. But it's a really important part of this story. So Beth, let's talk about, we know that medication-assisted treatment, or MAT, is part of the decline, that little decline that we noted. Tell us about that accessing medication-assisted treatment. How important is this in pushing back against the epidemic?
It's so important because we know that if you have steady access to buprenorphine or methadone, and buprenorphine is often called Suboxone, so I might say that, and I usually say MAT, although we're supposed to say medicines for opioid use disorder, we know that you have a 50-60% less likely chance of dying, as opposed to abstinence, which is 8 to 10%. So I mean, and the data on bupe goes back to the 1980s. We have really clear data on bupe and on methadone. And bupe is easier to use because it tends to be outpatient once a week, and then you don't have to go as often. Methadone is more of the daily thing. It is thought to be more efficacious in an era of fentanyl, But there's still a lot of barriers from so many people, especially people of color, Native American overdose deaths are going through the roof. So why is there such stigma about bupe? And there's this idea going back to 12-step programs that if you take a medicine, it's just that abstinence should be the only goal. And if you take a medicine, you're just treating a problem with another drug. And we know that alcoholism and opioid use disorder are so different. And that was really important that we show that in the Hulu show, too, because there's a scene where Michael Keaton's at a rehab, and he's talking to some other guy. And he's like, how many times have you been here? And what was it for? And it's just like, it dawns on him, abstinence is not going to work for me. And I think the best comparison is to say, you wouldn't tell a diabetic they can't take insulin because that is the evidence-based practice for a diabetes. You wouldn't do that. So why would you tell a person with OUD that they can't have buprenorphine or methadone? So,
and Beth, I think that because we are here as guests of an organization that does such incredible work in ethics and medical ethics, the question that I think is so fascinating is people who push back against this idea of medication-assisted treatment say, well, wait a second, you're just replacing one drug with another. And I think the question that's really worth thinking about is what are the ethical factors that really sort of weigh into this? And it's the same thing with harm reduction.
Absolutely.
Right? Are you giving people who have an addiction to drugs? Mm-hmm. And I think that's something that you have taken on in such a wonderful way in your books, and then in Dopesick, you really put that out there.
Thank you. And Danny, who was the showrunner and the main writer
Danny
of the
Strong,
show, Danny Strong, he got it immediately in some of our first meetings. He is a social justice warrior, and he basically let us put this wonky thing into a show because, guess what? Sadly, more people watch TV than read books. I don't agree with it, but it's true. He knew that we had the chance to make this just huge impact. If you see an A-list actor like Michael Keaton, whose character is a doctor, a beloved country doctor, even he struggles to get on methadone. And then he hears about buprenorphine, he struggles to get on that. He struggles to get his license back. And we had a great writer's room. There was a person in the room who had gone to a methadone clinic during college, and that was super helpful. We brought in Dr. Steve Lloyd, who the Michael Keaton character is loosely based on, him and some other folks, but Steve had been a main character in the book Dopesick. We brought him into the room, and he told us about his journey. And so when you see Michael Keaton like taking his patient's pills because he's gonna write him a higher dose of oxy, and then he puts them in a drawer and then he takes them, and these are things Dr. Steve did. And there was a way to make that storyline really, I think, come alive in the show in a way that may have been wonky in lesser skilled hands than Danny's. And what I love about it is, a lot of people watched it, millions of people watched it, and it came out during COVID, and one of our writers...
it struck a nerve, I think. How many people had an opportunity to see at least part of Dopesick? Yeah, I mean, that just doesn't happen.
Yeah.
Take it from me, somebody who's making documentaries, that doesn't happen.
One of our writers in the room was standing in line at CVS here in New York, and he had a Hulu face mask on. And this woman behind him said, "Hey, have you seen that show, Dopesick?" And he goes, "Yeah, actually, I worked on it." And she said, "I watched that show, and for the first time in 3 years, I called my addicted son."
Seriously?
Mm-hmm. That was all I need to hear.
Oh, that's amazing.
It gives me goosebumps just saying it.
For sure.
It changed the way people think about it, I mean...
it's so true, and I have the privilege of making documentaries that are based on public health issues. And I have to say, watch and did the documentary Warning This Drug May Kill You for HBO, which is an extraordinary place to be able to release a documentary. To see that versus what happened with Dopesick and the opportunity for narrative fiction based on real life was incredible.
Yeah.
It's how many people it could touch and how it could move the minds and the thinking around something that is so heavily stigmatized, which is drug addiction. So I thought it was, I'm sure you had that experience too, watching your book be translated into narrative fiction.
Oh, it's so exciting. And Danny and I we were re-reporting it. When people were leaking us memos that had never been published, and then we'd get on the phone with sales reps, and we really felt like, we were champions for this cause. It's very cool.
It's so true. And I think that especially around stigmatized topics, whether it's alcohol use or drug use or anything like that, the opportunity to be able to get it out there in story form. And it's to your point, Beth, it's really hard. I remember when I switched from news into documentary, the first one that I did was about access to health care for a woman with breast cancer. And I remember having this conversation at HBO. I'm like, yes, it's a great story. And she's like, access to health care? These topics. Anyway, but she finally
Hulu's
did.
the only one that wanted to make it.
Right.
Yeah.
Well, Last Laugh was on everybody else because it was an extraordinary, extraordinary success. Beth, we've thrown out that term harm reduction, and I think it's important. Let's talk about what harm reduction is, especially as it relates to opioid addiction.
Yeah, and harm reduction is really the crux of Raising Lazarus, the follow-up book. So harm reduction is most commonly thought of as a needle exchange, a place people with OUD could go to get not just needles that prevent the spread of hepatitis C and HIV, both of which are on the huge rise, but also a friendly face, food, information like which employers in town will hire a felon, a hug, and connections to care. So we know that people who go to needle exchanges are 5 times more likely to eventually seek treatment. And that is just so powerful. But there are so many political forces aligned against folks doing this work. And folks doing this work are such badasses. They really are. The things I've seen have just been so moving. And if I could talk a little bit about Tess.
Oh, definitely. Talk to us about Tess. I can ask the question.
Tess Henry is the person I followed for Dopesick, the book. So she was a young woman. She was from that same wealthy suburb I talked about earlier. Her dad was a surgeon. Her mom was a hospital nurse. And she got addicted initially at an urgent care center. She was prescribed 2 30-day opioids for bronchitis. One was Tussie caps for cough, and the other was hydrocodone for sore throat pain. And at the end of the 30 days, she started getting jittery. She put her symptoms into Google, she told me, and said, holy crap, I'm addicted. And she was working at a very high-end restaurant at the time, and a friend of hers there knew how to get her the pills, and when the pills got hard to get, knew how to get her the heroin. She started snorting, then she started shooting up when the snorting didn't help her from being dope sick. And so I followed her journey for 18 months to 2 years. And she really wanted people to know how hard it was for her to get on MAT. There were waiting lists. The only person that would see her was in Blacksburg, 45 minutes away. It was $500 cash for the first visit, $100 a week after that. And she gave birth while she was in active addiction. Nobody at the hospital would give her MAT. Her mom said, you can't discharge her, that's unsafe. So they kept her another day, and then they went straight from the hospital to the methadone clinic. I mean, is that any way to be carrying a newborn baby
it's
around?
Awful.
I mean, I saw her struggle so much, and her family didn't know how to deal with it, which is not uncommon. And they all just thought, if she hits bottom, she'll get better. And her mom would now tell you that the bottom has a basement, and the basement has a trapdoor, right? Because Tessie was eventually sent to an abstinence-only rehab in Las Vegas. And when she failed out of that, she checked herself out against medical advice. She was then on the streets of Las Vegas, living in an abandoned minivan with her pimp, doing sex work, and she was brutally murdered on Christmas Eve of 2017. And as I'd already turned the book in, I rewrote the ending, I followed the whole thing with her mother, and I mean, there was just so much pain. And then when the book came out, it was, of course, very stressful, not just like taking on big pharma, but also just experiencing this with Tess. And my husband said, you should write a cookbook next. Right? You should do something light. They never let us do anything light, did they?
No.
Never. And, but as I went around starting to talk about Dopesick, I started to hear things that were working. And I got really lit up because it was mainly harm reduction stuff. I got really lit up when a person figured out harm reduction in a red state, in a rural county, in Mayberry, literally Mayberry, North Carolina. They were doing some really cool stuff. And I thought, this is what Tess meant. Because the very first time I interviewed Tess was 2015. She told me about all the barriers. And she said, what we need is urgent care for the addicted. She didn't know what that looked like because she knew she got addicted from an urgent care. She also had a lot of trauma in her background, and that's another contributing cause. But she didn't know what urgent care for the addicted looked like, and I didn't either because I too had never seen it. And until I started hanging out with these people doing harm reduction work, and really sorry, it's such a long answer, but the idea of a harm reduction is going to people where they are, even if they're in a homeless encampment, even if they're living on the streets, and going to them not with we got to get you better, you got to stop using drugs, but we're going to literally meet you where you are. Even if you're still using, we're going to treat you like a human being. And so Raising Lazarus begins next to a McDonald's dumpster in a distressed community in rural North Carolina, a red state that hadn't yet passed the Medicaid expansion, with a nurse practitioner who works for a harm reduction group, meeting a person in active use, and the guy shows up late, he's high, it's the height of COVID, he has a dangling face mask, a broken face mask dangling from one ear, and Tim, the nurse practitioner, says, I'm gonna call in a discount buprenorphine prescription. You can pick it up at this particular Walgreens tomorrow. But before you leave here today, and the guy was crying, he said, if I don't stop shooting up, I'm gonna die. I know that. And Tim said two things. One, you can get better. So it's like, most Americans have given up on this population, right? 13%. Treatment gap, 87%. And a lot of people with OUD themselves don't think they can get better. But he said, you can get better. And then secondly, don't disappear, which is this idea of I'm still with you even if you return to use, which, takes some counterintuitive thinking, right? So he said, I'll meet you here next week, but if you can't come, text me and I'll come to wherever you are. And that was really revelatory to me. I mean, it just gave me goosebumps. And that guy, I'm not sure where he is today, but I know other people that I met with Tim who have gone from living in a tent to losing their children to having to borrow a car to get to the clinic. And now they are working as peer support specialists. They're not just better, they're helping. And that's so moving to me. But it all starts with harm reduction.
And harm reduction, again, getting back to that same sort of question that people have is, how can we give needles to people who are using drugs? It's those same thorny issues that come up in medication-assisted treatment or MAT. And I want to add, because you mentioned two things about big pharma, but also that people have largely given up on this population of people. And when my reporting kind of kicked in on this story, it was really about people who had become addicted because a well-intentioned physician had prescribed an opioid, and then these people, became addicted, and then switched over when the prescriptions ran out to heroin and then fentanyl. And the one thing that I took away from that is there's this thesis out there, I feel, that people give up on people who are addicts because they think at some level they are bad people. Mm-hmm. And that they're bad people, and in particular, as it related to big pharma, who were abusing good drugs mm-hmm. that were intended for people who were in pain. And that was something that big pharma was really putting out there. And just to make clear, these are good people who have developed a medical condition called addiction. And I think that, so much of that is what plays out in Dopesick.
Yeah, and it's a treatable medical condition.
That's right, exactly.
Yeah.
That's exactly right. Let's talk about the use of evidence-based care in unexpected places that you really do so much reporting on, Beth.
Yeah, well, I told you the story about Tim and Michelle. Michelle Mathis is, she started, before needle exchange was even legal in North Carolina, she started out with her wife, Karen Lowe. They run what they call the nation's first queer, biracial, faith-based harm reduction organization. Say that 5 times real fast. And they have matching tattoos that say acta non verba on their arms, which is Latin for do shit, don't just talk about it. So when I started following them, they started out giving out food to needy people. Literally, it was a ministry called Olive Branch Ministries. And then they quickly realized a lot of people were injecting. So they said, oh, if we dump out half a box of granola bars, 10 needles fits in there perfect. So then they started doing it on the sly. They would put a card in there that just said the name of their ministry with a phone number so that if grandma found it, they'd think, oh, how nice they're going to church. And then they started, they just stayed with it, and they made relationships with people, and also with law enforcement. And you'll hear from harm reductionists, we got to meet them where they are, but Michelle and Karen also say, you got to meet the other side where they are too. So they started making these relationships with law enforcement who didn't understand harm reduction, who didn't understand MAT, started helping folks coming out of jail deal with their charges and that kind of thing, and really being advocates. And then to the place where they're doing, they now have 3 standalone needle exchanges. They have mobile, where they have peers driving around to 10 encampments. And then they have people like Tim going out doing, it's called low barrier buprenorphine treatment. And that is evidence-based care. When Danny read Raising Lazarus, he said, I get it now. Our showrunner, he said, MAT is a gateway to treatment, and harm reduction is a gateway to MAT. And I was like, damn, it took me 10 years to figure that out. You just said it in one sentence. That Danny. But that's what it is. And we have to bring it to scale to match the scale of the crisis. I mean, that's what's missing.
Absolutely. And when we talk about scale, and mentioned big pharma, as everyone knows, there have been lots of settlements, lots and lots of public outcry. Beth, and obviously we could be spending this entire time tonight talking about pharmaceutical companies, which we're not going to do, but I'm curious, where do you see us vis-a-vis, how is that money, is that money trickling out of pharma? Yeah. And is it getting where it needs to go?
It's beginning to. I mean, about a year ago, it started coming down, and it was mainly the big distributor payout, 20-some billion. But the thing is, some states have really said, we're only using it for evidence-based. And if you want to bird dog this, there's a great reporter named Aneri Paterni who she's got a database set up through Kaiser Health, Kaiser something Foundation. Yeah. And where you can put in your community and you can see where that money is going. And she's found out some shocking things. I mean, some places like New York State has really clear goals for that, how the money should be spent. But there are small towns in rural Mississippi and elsewhere where the sheriffs want it and they want to buy cop cars with it. That is not what that money is supposed to be used for. There's a harm reduction group called Truth Farm out of Binghamton, New York. And whenever the New York Opioid Abatement Authority meets, I don't know if they're still doing this, but initially they were. She has her whole group of rainmakers, which are her peer support specialists, and her this really big activist group. They go and they plant a makeshift cemetery outside of wherever they're meeting. So it's mothers and sisters and brothers of the dead who have made these tombstones of their dead loved ones, and it's very powerful. They also put them outside of Judge Drain's courthouse for the Purdue case when that was going on, in cahoots with Nan Golden, the famous photographer who was really lit a fire under a lot of this, take the Sackler name down from museums and whatnot. So we have to make sure that money is spent correctly. The tobacco settlement remains the largest settlement in American history, 270 some billion, and only 3% of that money went to where it was supposed to go to, which is for the prevention of smoking.
Which
and
is
treatment.
outrageous.
It's outrageous.
You told me that before we came out here, and I was shocked. I never heard that.
Yeah, it's
big.
It's true. And so we know that every dollar that we spend on treatment saves $12 in reduced criminal justice and healthcare costs. So it really is important that money gets spent the right way.
When you talk about money spent, it begs the question, what does the medical system owe the 2 million plus people who are addicted to opioids? And I use the word owe purposefully.
Yeah. Well, when I was first out talking about Dopesick, even before the book came out, I spoke to a group of doctors and med students in Roanoke, Virginia, where I live. And Tessa's mom had just given me a necklace. She had been gone about 6 months. And it was a locket, and it had this E.E. Cummings poem that she loved, which was that one that goes, "I carry your heart, I carry it in my heart." And it was engraved on the outside, and I had a picture of Tess inside with her rescue dog, which was kind of how I met her, long story. But I would hold up the necklace, and I would show the picture of Tess, and I would say, "Look, I know not all of you took a free trip to Scarsdale or Florida to get your big Purdue junket, but you participated in a system that got 2 million people addicted. You participated in it, even if you weren't active participants in it. What are you going to do to help get them out of it, right?" And so at the time, the ER wasn't doing anything. They would treat a wound or treat an endocarditis, and then the person would leave with a Xerox of AA meetings. And there was no connection to care. And when I asked the head of the ER, "Why aren't you doing buprenorphine? Why aren't you setting that up with the outpatient clinic?" He would say, "Well, that's just treating a drug addiction with another drug. That's not in our purview." Our purview. He was very, he was sad about it, but he was also very pessimistic. And so I called him back 2 years later, and I said, "Hey, I hear you're doing, like almost overnight, you're doing evidence-based medicine in the ER. Not only that, you're connecting somebody in this crisis, which is a moment when we can actually reach these hard-to-reach folks, setting them up with a peer. They've got 3 or 4 days worth of buprenorphine. You've got them, they're coming back to the outpatient clinic within 3 or 4 days." And he said, "Yeah, we got like 30 people into treatment the first month alone." I said, "What's that feel like?" He said, "It feels like doing mental cartwheels." And he was so positive. And, I record all my interviews, and you can hear him being pessimistic and then being optimistic because he's not seeing the same people cycling in and out. He is seeing that the secret to the care of the patient, as the famous physician said in 1926, is to care for the patient, right? So now he's going and teaching other people. But I said, "Dr. Burton, what made you change your mind?" And he said, "Well, we read your book."
I love that.
Right? I was like,
"Yes,
I'm recording." And then he said, "Then we read the data." And we said, "How can we not be doing that?" And so I love that. So he's now a leader teaching other hospital systems how to do this. So that's what we've got to do. That's another form of urgent care for the addicted. We are still churning out doctors who don't know how to recognize and treat opioid use disorder. You might disagree, but I have really good friends who just spent 9 hours taking the internal medicine boards, graduates of Harvard Med. Guess how many questions in a 9-hour test had anything to do with addiction?
0.
2.
Oh,
2.
Okay.
One of the answers to one of them was wrong. So we've got to start doing that. We need, especially in rural communities, which have disproportionately suffered from this, we need to incentivize general practitioners to go to those folks where they are, because they've been screwed first with job losses and globalization, and then these exact communities, the maps almost match perfectly, are where the pill mills and the Purdue reps focused. Even after they got in trouble, they hired McKinsey to teach them how to double down and go after the really bad doctors, because they said, well, if you have one really bad doctor, they'll sell a whole bunch and we'll get even richer.
And that's when they knew that these were really highly addictive drugs.
Yeah.
That's its own story, which is really an extraordinary story and stain, in my opinion, on the pharmaceutical industry in this country. However, we won't go back there again. But the criminal justice system and the opioid epidemic has a really complicated, unfair, ethically challenged response, which is if you are one color, you go to treatment, and if you are another color, you go to prison. And I don't have to tell you which is which, because I'm going to have you, Beth, explain. Talk to us about what the criminal justice system, how do they play a role in what is unfolding in this epidemic?
Absolutely. Well, we know that when so many of these folks are cycling in and out of jail and prison, and we know that when they get out, they're 40 times more likely to die if they return to use, because they've been opioid naive while in jail. And
explain just what opioid naive means, just in case somebody doesn't know what that is.
Theoretically, they haven't been using.
Right.
So
their tolerance is way down.
Yeah.
Right.
And then you go back and there's all kinds of new synthetic opioids in the supply. And so they're much more likely to die. In Lazarus, I profile a jailer, a sheriff in Fairfax County. And granted, it's a blue dot. It's right outside of DC. It's a huge county. But again, she did the research, and she invited this harm reduction group in called the Chris Atwood Foundation, started by a young woman who had lost her brother, who was living with her, didn't know that she should have had Narcan at her house. This is back in 2014. She said, how did I not know about Narcan? She ended up getting the laws changed in Virginia, where you can get Narcan over the counter, and many other things. But what she's done with the Fairfax County Jail is now when anybody comes into the jail, they get screened for OUD, they get hooked up with a therapist, run through the state-sponsored Community Services Board, and the therapist, by the way, their office is in the jail. That's pretty unusual. And they just exude kindness. Anyone who wants MAT can get on it, but most importantly, the peers, and these are peer support specialists. Do we have any peers in the room tonight? Yes. Peers are the secret sauce to all of this. These are folks in recovery who will guide people through this. And so Ginny at Chris Atwood Foundation would bring her peers in, and the peers would get to know the folks who were in addiction treatment while in jail. And they would work on a plan for that moment of release when they're so vulnerable. And then when they would get released, they would get a buprenorphine prescription, they would get Narcan, and then the peer would actually pick them up at that moment and take them where they had been planning to go to the next step, whether it's a rehab or an Oxford House type thing. And the sheriff had a hell of a time talking her deputies into doing this. He said, we're going to give them buprenorphine. Some of them are in here for illicitly selling buprenorphine. We're going to let peers with badges, all of whom were felons, we're going to give them badges and let them come in and out of the jail at will? And the sheriff said, yeah, because that's what the evidence says. And she had been to other jails and seen how it worked. And some of those deputies had to be let go. And just a reminder that the sheriff is still the highest elected law enforcement official in the nation. They're like fiefdoms. And a bad sheriff can do a whole lot of damage, and a good sheriff can do a whole lot of good things. And so we really wanted to show who is doing good things in the space and sort of elevate that work.
Yeah, absolutely. Beth, you started this conversation by saying that probably everybody in this room has touched, knows someone who has been impacted by an opioid addiction or opioid use disorder. what can each of us do? What do we need to know for the people who we know, we love, we care about, et cetera, who may be impacted?
That is such a hard question. I mean,
that's why they pay me the big bucks.
it's such a hard question. I had a woman at a talk I was giving at a library fundraiser last week, and she just told this out of story about her daughter is, out on the streets and she doesn't know what to do, but she doesn't really want her to come home because it's so much pain. It's that whole idea they're going to mess up Thanksgiving dinner, and what do I do? And I said, it's like the airplane mask. First, you have to put the mask on yourself. You have to get help. You have to get professional help, because this is really hard. We have experienced this in our own family with our own child. It wasn't opioids, and we had to reach out for help, professional help. We had to learn how to set boundaries, how to take care of ourselves. And the boundaries is really, really hard. And the other thing I tell people is, you've got to connect with the local harm reduction group. You've got to get your person in with a peer. And because that makes such a huge difference. I say peers like scar tissue on your hand. It's tougher than the rest of your hand. I had a mountain bike wreck here years ago. I've got a bunch of plates in here. So it's they're tougher than we are. They have been through everything. They know how to navigate. And the other thing I never miss a chance to tell an audience is that you are people of goodwill, or you wouldn't be here unless your teacher made you. You have social capital. So if you know a probation officer who's just nasty and doesn't believe in MAT, have another probation officer who does. Talk to them, because we know they hear it better from somebody like them. If there are examples all over the book of judges changing their mind, who used to be really tough on crime, and now they're doing really evidence-based drug recovery courts and allowing MAT, and doing things like when somebody's had a really good week and they come in front of the judge. I watched this judge in rural Tennessee, of all places, get out from under his bench and go give him a hug. Sometimes it's just not treating people like shit that's going to be the most important thing. When I was following Tim, that nurse practitioner that I talked about at the McDonald's dumpster, he said, I want you to come down and I want you to come spend a day at the clinic where I work. He works at a federally qualified health center, mainly doing HIV and addiction. And he wanted me to come down because he wanted me to meet this peer support specialist named Nicole, who manned the front desk. And I was like, okay, I'll do that. And he said, no, it's really, really important that she mans the front desk. So I stood there for 2 hours, and she was just nice to everyone who came in. And there was a woman in the back who was trying to work up the nerve to go say she was here. And she was hangdog. And she said, Nicole said, hi, honey, how are you? How can I help you? And she said, it's awful. And Nicole said, I'm in recovery. And she said, it's bad. I live in a tent. I don't have my kids. I had to borrow a car to get here. And Nicole said, I'm in recovery. We can treat you on a sliding scale. And she just listened to her. And we now have data that shows that this works. But I always tell this story when I'm speaking to people. Who you have at the front desk is really, really important. Lab technicians who treat people like crap. Hospital employees who treat people like crap. I know of a young 28-year-old with end-stage endocarditis who chose to die at home alone rather than go back to the hospital where she'd been at the week before because they treated her like crap.
I'm gonna jump in because we're almost out of time before we take questions to ask you, because I promised that we would get there, which is that what are you working on now?
Yeah.
I teased the title.
Yeah.
But I'm gonna let you got a minute though.
Yeah, we're still arguing about the subtitle, so I won't say that. But it's called Paper Girl. I grew up poor in a rural town in Ohio, and it's one of these towns that has gradually, sort of in slow motion, become very distressed. It still looks cute on the outside. But I was the first person in my family to go to college. I went in that rare window when a poor kid could get a Pell Grant to pay for the whole freight. So now a poor kid would have like 30% paid for. That's not going to cut it, right? I wouldn't have been able to go. So I'm writing about how do we get to this place in America, and what is the role of local news and the demise of local news? What has that played in our polarization, our national unraveling? Why we can't have Thanksgiving dinner together, right? So I went back to my hometown for the last 2 years, and I've embedded in my home community to try to write about why it's changed. And I did not want to write a third book about the opioid crisis. I promise you I'd much rather write a cookbook. But that's what I'm seeing. I'm seeing it's like the reality version of Demon Copperhead. Do y'all know that book? That's the best book I've ever read by Barbara Kingsolver. It's a novel, but she did so much great research on what it's like for children born into this. We've had 500,000 children become orphans because of this.
Yep.
So,
all right, question time. I have questions right here. Michelle, is there any order that these are in? After me, okay. All right.
only ask me things I know the answer to.
Yeah, right, exactly. Beth, what is the responsibility of physicians to work with patients to wean them off opioids? A wonderful scene in Dopesick as well. So what is the responsibility of a physician to help patients get off of opioids, oftentimes the very drugs that have been prescribed by them?
Do you mean getting off buprenorphine?
No, no, opioids.
Right. So I heard a lot, when Dopesick came out, it was really before there was a lot known about the fact that pain patients were just being cut off. And when a pain patient gets cut off from their stable, legit opioid prescription, the same thing's gonna happen to them that happened to Tess, right? It doesn't matter that they were prescribed. And a lot of them were going to the black market and dying or committing suicide. And we know more about that now. And we know that it needs, like, it shouldn't be a forced taper. It should be done in a really humanistic way. And very, very slowly with the patient's buy-in. And maybe it doesn't work the first time. So that's what I would say to that.
Really, and very difficult to do. When I was reporting on this, there was a wonderful, wonderful doctor down in Tennessee. Is that right? No, Mississippi. And he had become addicted and realized that he had addicted most of his practice. This was in the 1990s when Purdue was really out aggressively pushing it. And he had to go away for treatment for 3 months because that's what physicians have to do and pilots, and then came back and started 12-stepping and doing medication-assisted treatment in his office to try and get his entire practice back off of opioids, and was moderately successful, but really, really hard. So thank you.
Really hard.
Really
and I'll
hard.
hear a lot. I'll have parents come up to me and say, yeah, but when are they going to get off the buprenorphine?
Right.
That's harder to get off than heroin. And I would say what Dr. Van Zee would say, and he was really the first doctor in the nation to fight back against Purdue, is like, some of my patients are just on like a couple, the smallest dosage, but I would not take them off because, I mean, it's not unlike insulin. They might have to be on it for the rest of their life.
That's
and
right.
There's no like hard and fast rule, and the patient has to have the input in it.
Our next question is a complicated one and related to the last one, which is, in what ways can we address the opioid epidemic while protecting the chronic pain palliative care patients who need and qualify for appropriate use of pain medication? Why do you think we find ourselves in a place where addicts can easily score while pain patients struggle to get their pain medication?
Yeah. I mean, I think I just answered that.
Yeah,
but I would also add that, we wouldn't be in this place if Purdue hadn't come out with this under its false narrative that, pain is wildly untreated and the cure is their medication.
Yes.
But again, and it's something that that it's not an easy thing, but physicians have to be willing to do the hard work of really spending time with these patients. And also, pain management isn't taught to the level similar to addiction.
No.
There should be in medical
Pain
schools.
management is really hard, and I think that there was a real swing towards making these medications really hard to get in the aftermath of everything that happened with the settlements, and I think it's swinging back a little bit and normalizing a little bit. But it's a complicated tension and a good question. Okay, Beth, if you could change or implement one health policy that you believe would significantly impact the opioid crisis and reshape the current landscape, what would it be and why? So one health policy.
I would have walk-in clinics. So whether that's through a federally qualified health center, a place where you can go and, just like Tess said, get urgent care. There's a place in Huntington, West Virginia. If y'all remember, there was a day, and it's a small city in West Virginia, hammered hard by pill mills, where there were 26 overdoses in one day. And the fire chief told me, she's now the opioid response director. She is now Narcanning the children and grandchildren of the people she first Narcaned when OxyContin came out. And so what she and that community has done is, one, they have like a rehab for women and children, which is very rare. Roanoke is about to get one, and I'm super excited about that. So a place where somebody like Tess could have taken her young son. There were only 2 in the whole state at the time. So, but the one thing I would do is like a walk-in clinic where somebody can automatically get treated and get help with housing and social supports and counseling and connected to a peer. That was a little bit of a fake answer because there are a lot of other answers in it.
We take fake answers.
Okay.
We're good. Okay, great question. How and to what extent does the opioid crisis relate to what has been described as the loneliness crisis?
I am sure they are related.
You can also take a pass.
No, I want to talk about a doctor I met in my hometown. So, it's really hard for rural places to get physicians to come and move there because they're not the most attractive places. But she got free medical school in exchange for moving back to a rural place. And she works at the brand new federally qualified health center. And she's 2/3 are mental health and addiction of the folks that come. And she wanted to be a vet, but she said, I can't handle people getting $1,000 care for their cat and people not getting that. So she went into medicine. But she says the main thing she does is she just listens to people. And I said, how do you stay upbeat? I get that question a lot. How do you stay upbeat? She said, I celebrate the small wins. Maybe they just showed up for the appointment. Maybe they got their diabetes under control or their blood pressure under control. But mostly I just listen because everyone is so lonely.
How much time do we have left? Lots of. How much? Oh my gosh, there's so much pressure. Okay.
You're doing great.
Beth, our policy responses to the we got a whole new pile though. Our policy responses to the opioid crisis, as polarized as the rest of U.S. policy seems to be these days, are there areas of agreement or values overlap that suggest policy solutions are possible? That's a really good question.
It's a tough one. Well, I think the Affordable Care Act has been the #1 way to get people treatment. I mean, the evidence bears that out. In our current climate, we're not even sure if we'll still have the Affordable Care Act, which frightens me. And so some of the things we can do to mitigate that is we can go to these gritty harm reductionists and we can help them. So I always tell people, because they'll say, what can we do just as regular citizens? You can go pack Narcan kits for your harm reduction group. I had a doctor in the audience, recently retired. She goes every Thursday and she does wound care for the harm reduction group. a minister said, "Can I have the mobile needle exchange clinic set up in my parking lot at the church?" I was like, "Yes, you can." And so we just really need to protect these people. And but it's just like the uneven states of America. If you have opioid use disorder and you live in Massachusetts, you are so much more likely to get care than if you live in rural Mississippi.
No question about that.
It's just so alarming
Unfair.
to me, but I really hope we can protect the Affordable Care Act and expand it. We still have 10 states, I think it's 10, that haven't yet expanded it.
All right, I'm moving on because the timing. Okay, this is an important question, Beth. What warning signs should parents and caregivers look for in younger children who have access to opioids? Really tough one.
Yeah.
Different than alcohol, much more difficult to detect often.
Yeah. Changes in mood, changes in behaviors. Used to love to play soccer, used to love to play the piano, doesn't want to do it anymore. I always tell folks, get those opioids out of your medicine cabinets. I mean, I can't tell you how many kids have gotten it from grandmas or those leftover meds that are still in the cabinet from your arm surgery or whatever. Get those out. Talk to your kids about the fact that one pill can kill. We lost...
Especially now that they're oftentimes laced with fentanyl.
Yeah.
Which is really bad.
We had a guy arrested at our local community college. He was selling fake Xanax bars that were actually fentanyl. I mean, it could have killed thousands of people. And, these kids don't even know.
It's really accessible right now on social media, in particular Snapchat.
Yeah.
It's a real problem. I'm doing a documentary about that. Shameless self-promotion.
Excellent.
Okay.
What's it called?
It's not out yet, but it's called, right now the working title is I Can't Look Away. So
wow.
it's
good.
under development. But anyway, it's really important because the drug dealer is now coming into people's own homes via social media. Okay, but that I didn't mean to.
So we lost 1,000 teenagers year before last, and they weren't even people who were addicted. They were just people getting something else they thought they were getting.
How many minutes? Was that? How much? Oh, okay,
10. We
great.
went from 9 to 10. Wow. She's easy.
I'm good. No, that's it. What's the most effective way at reducing stigma faced by people with opioid use disorder among decision makers like judges, law enforcement, CEOs, and elected officials? How do we change stigma?
Yeah. Well, we change them by telling the stories of the people who are doing the right things, right? I mean, that's what you and I are doing. We change stories when people get out of their comfort zones and learn why buprenorphine is an evidence-based care, and then go teach other people why. With that 2/3 number, 2/3 of families that are impacted, I mean, we need to be changing the stigma because it's out there. And when people see that people do recover, like the Michael Keaton character, like your doctor friend, like my doctor friend, it's really powerful. You know, Dr. Steve Lloyd, he's now the opioid response director for both West Virginia and Tennessee. He has saved more lives than anyone I can think of with this. And is constantly testifying before Congress, meeting with the drug czar. And to see somebody with his stature that's still, I mean, I met some of his patients at the methadone clinic that he runs, and she was telling these stories about having to use a Kotex pad in jail because nobody would help her with her wound from injecting drugs. I mean, he's with them. And if you see people like that, and that's why the stories are so important.
And I think also stigma, when it comes to stigma, when people have an addiction or opioid use disorder, we don't talk about it and tend to push it aside. We've got to talk about it. And hopefully that will sort of blow away some of the cobwebs of stigma, which is a killer.
Yeah.
It really is. Okay. I'm going to skip that for now. talked about the relationship between marijuana and the opioid crisis.
That's a sticky one. What Nora Volkow, the head of the National Institutes of Drug Abuse, would say is that we have evidence for medicines for opioid use disorder being the best way out of this. We don't have that evidence for marijuana yet. But when you talk to people, I hear from a lot of people that will totally snap back on that and say, dude, that's why I'm not doing opioids. I'm smoking weed, right? And so maybe we just don't have the evidence yet on that. But there was a really strong series in the Times recently about the impact of how strong marijuana is now. It's not your grandma's marijuana. And particularly on developing brains before the age of 26, that it can cause psychosis. So it's another one of those nuanced, no easy answers, right?
Yeah. Okay, I'll give you another no easy answer. You ready?
No, thanks. Come on, Dr. Peltz.
And this is going to be our last question. Would love to know more about how the attitudes towards medication-assisted therapy are hopefully evolving in some of the more rural areas of the country.
Yeah, I think that's true. It's the criminal justice system that has the most work to do with this. It's the doctors too who don't want those people in their waiting rooms, right? You used to have to become waivered to prescribe buprenorphine, even though you didn't have to have a special certificate to prescribe OxyContin. So we got rid of that. Biden signed the MAD Act. That helped with that. But it's still voluntary. You can't make a doctor prescribe buprenorphine. So I do know that younger docs are really wanting to make a difference because they've lost friends, and that's good. But we still have a long way to go before we can scale that up.
5 more minutes? Oh. What is the most underrated avenue for remediation of the opioid crisis?
Underrated avenue. Probably peers. I mean, if we had peers stationed everywhere, like in hospitals, in homeless shelters, I have just seen them perform magic time and again. They will stand outside of methadone clinics handing out needles. They will, one told me she had to babysit a drug dealer's dog. Don't ask. It's just they'll do anything to help somebody get into care. And it's a low cost. It's also a great avenue for folks with felony records coming out of prison and jail to get a certificate. It's a big workforce issue. And I think if we could scale that up, it would make a huge difference. But again, it's the stigma. Oh, we don't want those people. We don't want them to have a badge and come into our facility.
Right, that's right. You mentioned this in our conversation about peer support specialists. What is the pathway to becoming a peer support specialist?
I don't know the answer to that. Would you like to answer that? What's the pathway? How did you become a peer?
All the states usually have certifying bodies. You contact them, ask them about it,
Okay. Okay. Yeah. Okay. And certainly a harm reduction group could connect you with that. You could Google it. And I know Ohio has this new fellowship program for peer certifications where you don't have to pay the cost for it. But, we need people to hire them too.
This is a great question. What can we as early career public health professionals do to advocate for this population?
Oh, what a great question.
I think that'll be the end question. How's that?
Yeah. First of all, thank you for doing that work. That's amazing. You're going to save lives. I'm just going to say it. You are. You could have done anything, but you care about this vulnerable population. How can we support you? Was that the question?
It was, yes. what can we do to advocate for this population?
Advocate for the population of OUD.
OUDs, yeah.
Yeah. Again, it's scaling up ways to reach folks who don't think they want to stop using, who don't think they can stop using, whether it's going to homeless shelters, whether it's bringing mobile needle exchanges into neighborhoods. It is all those places where people with OUD come into contact and they're afraid to come into like the real medical world because they've been treated so poorly. So if we could go to them where they are, as the phrase is, with non-judgment and, dare I say, with love.
On that note, Beth Macy, when is your book, Paper Girl, expected?
It comes out October 7th of 2025. Thank you all. This has been lovely. The questions were great. How about Dr. Peltz killing it?
No.
Yeah, we're really good.
That stole my end. Beth, what a treat to be able to have this conversation with you. Thank you, Michelle. Thank you to the Greenwall Foundation. Thank you, NYU. Thank you to this amazing audience. And let's hear it for truly the incredible Beth Macy.
Aww, back at you. Thank you.